call Krishna Kumar, sir. Please come up.
We know, as a physician, Indian physicians, we learned a lot in medical school. We are smart people. But how do we apply our knowledge in daily clinical situations? I'm going to go over there. You know that most important of the organ of the body is what? Talk to the girl, they will say it is heart. Talk to the nephrology, they will say the kidney. Talk to anybody else, pulmonary will say it is lung. But basically it is your brain which the most important organ of the body is. What brain really needs is only two things. What are those two things? One is glucose and second one is your oxygen. Right? On an average, everybody got enough glucose in their bodies to give glucose supply to the brain and to the rest of the body. But the oxygenation is a very dynamic process. How to get oxygen in your body, in your brain, is just only by one mechanism. What is that is? You got to breathe in oxygen and breathe out oxygen. Normally, room air oxygen concentration is about 21%. When we breathe in, we are breathing in 21%. When we breathe out, it is about 16%. That means we have extracted 5% of oxygen from the room air. Let's see how does it really affect us. We take the oxygen in, goes to the lungs, goes to the heart, and by the CVS system gets distributed to the whole body. Now, imagine if your brain does not get an oxygen. We all know that brain can tolerate anoxemia for how many minutes, how many seconds? Any idea? Take a pick, take any number, doesn't matter. In other words, try to hold your own breath. Let's see how long your brain is going to be active. Right? For example, just try to hold your breath. Let me see how much you can hold your breath. On the count of 3, I'll say, hold your breath, please. 1, 2, 3. Hold it, please. I'm going to keep counting. Who breaks out first? People sleep breathing? No, they are not breathing. They are holding the breath, right? See, somebody broke. 20 seconds, 30 seconds. You still going? All right. So on an average, a human being can hold their breath maybe for about 30 or 40 seconds, not minutes, not hours, 40 seconds. If you are regularly yoga guy, you can hold your breath for a little longer time. But how long? Maybe maximum 2 or 3 minutes. What happens after that? You start breaking your breath. Why? Brain start telling your body, hey guy, if you don't breathe for me, I'm going to die. Okay? Then people start breathing again after 2-3 minutes. Some people who are kind of divers, they can hold their breath in the water maybe for 3-4 minutes or 5 minutes. But no brain can tolerate an oxemia for more than 5 minutes. Right? If you can understand that, that means you understood the pathophysiology of the head injury. Now, let's apply that knowledge to our lecture here. These are just a number. That was about 5 years ago. Okay, why we have that? We are seeing every day traffic like this. Okay, everybody sharing the road. Okay, whether you're pedestrian or bicyclist or motorcyclist. All right. So what that means? We are prone to get head injuries. Every day you see so many accidents. Okay, what is the most important thing in the life? Is the life. If you get involved in the accident, you get hit, you get general body trauma, your brain is also affected, and you can imagine what happens to you. It's exactly the same thing is happening here now. Can you play the video, please? The video, this was recorded in Andhra Pradesh. How do people get the head injuries? Okay. You can imagine how the life is cheap here. What we can do a better job than that, right? We can definitely prevent the roadways traffic accidents, the biggest mortality causer in India, roadways traffic accidents. People who are in late 70s, 80s, and 90s, we can understand that. They're dying because of natural causes. These are the unnatural causes. People are dying on the street, and these are the healthy bodies. We deserve better than that. We have to avoid this. We have to make sure India is a safer country. And what we can do, we must do for India. Let's start with the case scenario. I have a 15-year-old guy who was working on the roof and he falls off the roof. Okay? And now, when we examine the patient, his initial Glasgow score is 12. You know Glasgow score is eye-opening, verbal as well as the motor. His GCS score is 12. Normally it should be 15. Okay? 14 and 15 is classified like a mild head injury. Moderate is about 8 to 12. Less than 8 is your severe head trauma. And after admission, his GCS goes down to the 6th. This is the biggest drop is. Now, what happens in the head injury? One thing you guys have to understand that what is that is, once your brain gets injured, you sustain a primary head injury. Primary head injury is not reversible. Whatever damage happened to the brain will stay there. Nothing you can do. But as a physician, what we can do, we can prevent secondary brain injury. That means we want to make sure if he's come across the patient who's a head injured, we want to make sure that brain gets enough oxygen. You know that when you're kind of out, when you sleep, your reflexes are down, breathing is down. Okay? But when brain is injured, okay, you become unconscious, lie down flat on the back, your oropharyngeal secretion keeps on going. When you become unconscious, your tongue falls backward. That obstructs your airway. That means you cannot breathe in. Ultimately, what is happening? That brain is not getting any oxygen. That is the biggest killer of head injury. That means if a guy who sees a head injury patient out in the street and who's not breathing, his job is to make sure patients start breathing. How we can do it? It's a simple maneuver. If you have head injury, chances are you might have some C-spine injuries too. That means what? You don't need to do head tilt and chin lift maneuver to breathe for the patient. All you have to do jaw thrust. Open up the jaw, and that is good enough to open up the airway, let the patient start breathing. That means what? Who the best treatment giver out on the street? It's not me, it's not you, it's the bystander who's sitting there, who's watching the scene, who's watching the accident. All we have to do as a physicians, we are smart people, want to make sure each and every citizen of India knows how to do CPR. If we can convey the message across the board, we did our job. Now, a brain who's sitting out on the street for half an hour, 1 hour, who's not breathing, you may transport the patient to the trauma center. You may transport the patient straight to those surgical OR. Nothing we can do because brain already sustained severe hypoxemia and oxemia. Right? So I'm going to stop there because I was given only 10 minutes. My message is we need to get everybody involved in the teaching people how to do bystander CPR, how to manage the airway of the patient. That is the most important thing is. If we can train all our police walas, if we can train all the school walas, if we can train anybody who wants to learn something, we must teach him science of the life and how to start resuscitation on those patients. If we can do that, we can minimize the mortality to probably more than 95%. What happened to the Maharaja Gajari's son? He fell off the horse. He couldn't even breathe. He was anoxemic for a prolonged period of time. Then let him have a vegetative body. Okay? We can do better job than that. All right? I'm open for any questions if you guys have any questions for me. Can maintain the airway. Plus, that is the only sure way of giving oxygen to the brain. Right? Now, certain myths about the hyperventilation. In head injury patients, you want to make sure PCOT is maintained between 30 to 35. Okay? People become sometimes very jealous in hyperventilating the patient. No doubt it does reduce some kind of cerebral edema because of the cerebral vasoconstriction. But at the same time, that makes the patient very hypoxemic too. You do not want to do it. So you want to maintain PCT around 30 to 35. A brief period of hyperventilation is okay to cut down up to 25, only for a brief period of time, nothing more than that. Same thing which I'm going to do here right now is little brief period of hyperventilation. Now this one, we did intubate the patient. But certain things you need to remember in head injury. You know our adult brain. You know what is the weight of your brain is? It's about 1.2, 1.3, something like that, liter or kilo, whatever. And the brain is enclosed in a closed shell. That means brain has no way to go anywhere. That is the reason you get early signs of cerebral edema. If you have same kind of injury on the leg or the thigh or arm, it has a space to expand. Our brain does not have much choice. Okay, 80% your brain material, 10% is your blood vessels, 10% is your CSF. It can play somewhere between 10 to 20%, not more than that. You know that if you are head injured, you have some kind of protective reflex, what is called it? Cushing's response, right? That means if you are head injured, your blood pressure shoots up. Why? It's the body's defense mechanism. Remember, do not cut that blood pressure. You lower down the blood pressure, you're going to cause cerebral hypoxemia and ischemia, and that is not good for the brain. Okay? So you do want to maintain that kind of hypertension. All right? Normal ICP is 10, more than 20 is abnormal, more than 40 is definitely severe ICP. Right. Now, this is a very vital slide here. Mean arterial pressure minus ICP intracranial pressure equal to cerebral perfusion pressure. Normally, MAP is 90. MAP mean arterial pressure is what? Systolic plus twice diastolic divided by 3. That makes your MAP. Okay? ICP is normally 10. Now, you're maintaining cerebral perfusion pressure of 80. Now, if your blood pressure goes up, why? Because the ICP is up. At the same time, cerebral perfusion pressure is still 80, that's a good thing. Okay, sometimes what happens, we become overzealous in the ICU, we start cutting down blood pressure, that is not good. Hypotension is a big no-no. Once you become hypotensive, you are killing the brain more. So don't do it. Okay. Few things you need to remember that what you should be doing is hyperoxemia is not good. Only normoxemia is good. Right? So you got to maintain the cerebral perfusion pressure too. Temperature, people were talking before cerebral cooling. They used to give there's the hypothermic fluids, okay, to make sure the brain is cool. I'm not really too sure it really works or not. In the adult population, they did say in ICU settings, cerebral cooling helps recover the patient better, okay. I'm not sure in the clinical settings. Second thing, got to avoid the hypoxemia. Third major killer is glucose. Normal blood sugar is what? 80 to 100. Hyperglycemia is deadly. Hyperglycemia is deadly. So is hypoglycemia. Hypoglycemia is not good either. So make sure blood sugar is normal too. And pH of the blood is extremely important too. Make sure that is also normal too. Besides that, everybody knows what else to do, what else not to do. Okay? You are much better than me on that token. I'm going to stop here right now. All right? I think it's better if it becomes interactive. Talk to me any question, anything. Okay? So I can really answer you. That is better to me. Right?
Are you suggesting that mannitol shouldn't be used?
It could be used briefly. You can use mannitol, you can use normal saline 3 centi.
That is what we were taught really, to start mannitol when the intracranial pressure is on the higher side. That is what we normally tend to do.
Right. Do you put the pressure monitoring system there? That's okay. They're perfectly all right to use mannitol or 3% saline, whatever you like. You can. But you cannot have.
That is why I said, when you said that we should not actually dabble with the high blood pressure, but that's what somehow that was new to me.
No. The blood pressure is healthy. That's helpful to me. What is killer here is the hypotension. You want to maintain the cerebral perfusion pressure. Now, if your MAP becomes kind of 60, for example, it's bad. All right? A blood pressure of 150 over 100, 110, that's okay, that's pretty good. Why high blood pressure is bad to us?
But if you have a blood pressure of 160 something, if you have a blood pressure of 160 or something, don't you think that mannitol should be used at that time?
I'm not sure on that token though. I do need to maintain cerebral perfusion pressure.
Cerebral perfusion can be maintained at 120,
but what is the ICP then? If ICP is your 40, your systolic 160, that's perfectly normal.
Okay, so that was new to me. I certainly wasn't aware.
Right. You got to maintain cerebral perfusion pressure. Anytime try to cut on cerebral perfusion pressure, that is the bad thing. Remember that. The brain is enclosed in the shell, big shell. There's not much of the scope to expand.
Things have moved on since we were students, say about 55 years ago. But that is what we were taught at that time, that the increase in intracranial pressure should normally lead to mannitol. We shouldn't really delay mannitol. And the other piece of wisdom that we were taught is that in head injury, never sedate the patient. That is what we were taught at that time.
I'm not sure about sedation too. Like appendicitis. Oh, this patient got abdominal pain. Let's not give morphine. Why? Because that is going to mask the symptoms. And we're going to miss the diagnosis.
Okay, thank you.
Right?
Regarding head injury, you are talking without me.
Yes, we were talking about you before you came. All right, go ahead. Now I'm so happy my counterpart is here, Dr. Ramesh and Mr. Come up here, please. Take some questions for our audience. Very renowned neurosurgeon, our batchmate. We are really, truly proud of him. He has done so many surgeries and he has benefited so many patients in the past. Let's see what his take is on the head injury patients. Yes, sir.
How is hyperoxemia harmful?
You want to talk about the hyperoxemia?
Who said this? Hyperbaric oxygen, you mean?
No, hyperoxemia.
Hyperoxemia. You want to have everything normal. There's a free radical, like in RDS patients, like in ARDS patients. High oxygen no good. If you want to know detail about pathophysiology, you can read it through, but it's a big no-no. Hyperoxemia. Hyperglycemia is a deadly disease.
A pathological hyperoxemia can never occur. It can never occur. If it has got self-regulatory mechanism. So if you give lot of oxygen, it doesn't mean that body is having hyperoxemia.
Those things that we were taught, things have moved on since then. I distinctly recall Those were the things that we were taught, and you have clarified. Thanks for clarifying that. Now, I'll be very, very careful, but I don't have to deal with head injury patients in any case, luckily. But I'll be very, very careful advising my juniors that if you get a blood pressure of 160, you shouldn't normally try to lower it by giving mannitol.
Yes,
And
because maintaining the cerebral perfusion is very important.
the other, now I recall.
But it doesn't mean that if you increase the blood pressure, perfusion will be good.
No,
it is not.
it's not increasing. If you
Only
find the
thing
blood
that
pressure to be in the
don't
region of
lower it,
160,
don't allow to be low.
If you find the blood pressure to be in the region of 160, what Kishan said is that then you leave it as such, you don't try to lower it.
Yeah.
That is what he said.
That was the whole sense of showing the screen.
Okay.
Okay.
The other bit was, of course, sedation. I asked that. I just recall, I was Professor Razdan's intern, and Professor Razdan was one of those very few clinicians at that time who never refrained from prescribing sedation in head injury patients. Head injury patients normally we were taught, but the Professor Razdan always used to say, okay, you can't actually mask the injury. So that is what I remember, just that. So that is what you were saying, that refraining from sedation is probably not always advisable.
No. Let me put the thing.
Okay, go ahead.
If you want to ventilate patients properly, sometimes you have to sedate because of the asynchronous activity between the ventilator and the respiration of the patient. So sometimes you have to sedate. Number two, there is one thing which is known as you paralyze the patient by pentothal, and just paralyze the patient and give the your whatever treatment you are giving, maybe the aggressive, maybe medical treatment, but put the patient on coma therapy. You comatose the patient. This is the ultimate in management of head injury. When you have failed, you are blunted on all sides, then you actually put the patient in the coma therapy.
Yes, the message is very much clear. So I think the discussion will go on. This time is not permitting me.
That's okay, that's fine.
Regarding hyperoxemia, because as a orthopedic, so far as I know with intensive care, that also suppresses the carbon dioxide and stimulation of the self-respiration.
Yes. I'm telling you, the pathological hyperoxemia is no entity, because this is self-regulatory mechanism. But it happens in the labs that if the drive, carbon dioxide related drive of the respiration, this will be blunted. This is obvious fact.
Because while weaning the person from ventilator, you have to reduce the oxygen dependence, so that
No, that is in graded form. That intensivist may really answer those questions.
Those are the important questions for COPD patients. Okay?
Especially those cases, if there is any trauma cases with any comorbid condition like COPD, in that case hyperoxemia is very harmful.
So then the
Because you
subject,
have
Normally,
the subject
see,
gets very much wide. You
Yeah,
see,
definitely,
so many
that's a very
things.
wide.
I don't think that we can cover up all those things.
all right. Anything else for me, sir?
thank you, sir.
So pre-hospital care is my thingy, and this is what I believe in. This is what makes a difference in the life. I think we are done. Try to invest your money in pre-hospital care. Thank you.
Thank you, Dr. Krishna Kumar, for enlightening us.